We'll start. Well, good evening, everyone, and we welcome you to today's event, which is a special event. It's a debate with the topic whether the online consultation removes the basic essence of a psychiatric consultation. We have two eminent speakers for our debate. Uh, First, the speaker who's speaking for is Dr. Josefa Bhindarwala, uh, a personal friend. He's also been a TED speaker. He's also a consultant psychiatrist at Prince Ali Khan and Saifi Hospital. Conducts a lot of speed reading workshops, which he's famous for. And well, of course, he's always a pleasure to hear. So we welcome you, Josefa. And our the speaker against is Dr. Rukshida Saida. She's a consultant psychiatrist with her clinic at Andheri. She's currently the secretary of the Indian Association of Biological Psychiatry. She's synonymous with women's mental health in the Indian Psychiatric Society. So she is part of that. She's also part of the Indian Association of Private Psychiatry in different capacities. And of course, she conducts a number of awareness programs, etc., within and outside her community, and is well known in the city of Mumbai. And she's also a TEDx speaker. So we welcome twice. So yes, so she has been twice. So the thing is, so we welcome her. So we have two TED speakers who are going to debate today. So the rules are that it will be 15 minutes per speaker, and then followed by approximately 4 to 5 minutes of rebuttal, or if less, whatever the speakers would like. There are no question answers because this is primarily a debate. And then we'll just thank the speakers and conclude. The recording will be put up on our YouTube channel. That is the Bombay Psychiatric Society YouTube channel for people to see and enjoy themselves even after today evening. So we start with you, Josefa. And I will not, I will probably just come in at 15 minutes to tell you, or 2 minutes before that your time is, you have 2 minutes left so that you have an idea. Yeah.
Thank you so much, Avinash, for giving us this opportunity to be on this debate. So without much ado, I'll be speaking for why offline consultations or meeting patients in person is always better than doing an online consultation. Our field has not gained as much respect among the medical professionals as it is, because they say you don't do enough. The least we can do is sit down with the patient and be face to face with them and talk, communicate, hear them out. I feel that when we are not face to face with a person, it impacts our clinical assessment. There is a lack of there is a lack of verbal communication that goes across so often because of errors in the network or because of technological issues. You will miss out on what the person said, and the other person on the other side of the screen will also miss out on what you are saying. Also, if the resolution of the patient's camera is not good enough, you will miss out on so many body language cues, which are so essential in our kind of work. And all this reduces the kind of rapport that you can build, particularly if it's a patient you're seeing the first time. So if I'm not wrong, you are at the mercy of the resolution and the technology that the patient possesses. Many of our patients are not well versed with how they should be sitting in front of the camera. So they will have a light behind their head. And by the time you get them to adjust the light or to change their position and be in a manner, you lose precious communication time. The other major clinical issue we face is that our paranoid schizophrenics, they already have some of their delusions, that I hope I'm being seen on camera. I hope nobody's recording me. And they will live with that fear that, that doctor I consulted, he also recorded, he now will share all my information with the rest of the world. Using Facebook, WhatsApp, what have you. So these anxieties build up in patients. The patients with social anxiety disorder, those are the patients that, you want them to be more social, you want them to come out and meet you and to interact with people. For them, this is a boon. That, I get to interact with my doctor and I'm happy, and, I don't need to meet him in person. But I think in a way we are reinforcing their social anxiety by allowing this kind of online interaction. Again, depending on the camera that the other person has, you may miss out on a lot of clinical features. You may miss out on scar marks on forearms of patients who attempt DSH. Sometimes they may be wearing clothes and you may miss out on scars around the neck. And so many things that are so vital for a psychiatrist to notice when one has to come to a diagnosis. Simple things like anemia, jaundice. Not that we are general physicians, but still we know that these have an impact on psychiatric health as well. So all in all, there is this missing human connection as far as clinical aspect goes. Now, there are two people in a psychiatric consultation. There is the doctor and then there is the patient. So let's look at the patient's angle. So many of our patients come to us with a very reluctant family, not allowing them to reach us. And when they have to consult from home, which is happening the norm now, because in the pandemic, people have gotten across through online consultations. They can't give a detailed history because in the small homes with the congestion and with people working from home, they are worried that they may be heard by their family members sitting in the other room. And the very person, the very issue that the person has, sometimes they find it difficult to express face to face. That leaves them with an option sometimes of messaging, and that I think becomes too much of going back and forth between you and the patient. 2 out of 5 patients that I have seen online, and I've had to, pandemic, 2 patients, for every 2 patients who would have preferred seeing me online, there are 5 patients who would have preferred me having a face-to-face consultation. And their constant question is, sir, ye hospital mein kabhi miloge? When will you meet us in person? Because there is a lack of belief in this kind of an interaction. And because of the lack of belief, they don't trust this interaction as much. They say, nahi sir, iske bawajud humko, we want to come and see you in person. Now in psychiatry, there is lack of belief, there is lack of trust, there is lack of faith, and I'm worried that has a direct impact on the clinical outcome of whatever we are trying to achieve. Many patients are camera shy, so they don't want to come in front of the camera. And they have a sense of lack of privacy because, at home, there are people moving around behind you and walking across. And there is this, not everybody has access to or is familiar with tools like the one we are using now, like Zoom. Exactly. So many times when you're online, the other person just doesn't hear you. Okay? And then this friend visits them. Reconnecting. And you are waiting, the patient is waiting and waiting. And then you connect again just to get reconnected again. So this kind of makes the whole interaction sometimes a challenging and very often a frustrating experience. Trust me, we don't enjoy it, but trust my patients more, they don't like it at all. Then there is the issue of senior citizens who have a hearing impairment. And they look at the camera, they put their head on the screen sometimes, and they bring the phone near their ears, and all you can see is those gray hair or the lack of them. They don't understand what you are saying. You don't understand whether they are understanding you clearly, and they give you a polite nod just because they don't want to be rude to the doctor. And that sometimes will, always pose a challenge when it comes to interacting with senior citizens. Then we come to the professional aspect. Because it's not a clinic, the ambience is just missing. The whole interaction, the whole clinical experience is missing. So you will have patients sometimes who will get in touch with, they will call you. They are lying down on their bed in their banyans, undergarments, and with absolutely no respect for who is there on the other side of the interaction. It would be nice to have, the more polished society always interacting with you in the professional way, but that's something we don't always have a choice of. And we have to cater even to the underprivileged section of the society, which sometimes don't understand these things. Also, there is the issue of distractions in their place. And sometimes, even though you are sitting in a very professional setup, you ensure family members not to interact. You are at home. So there are going to be distractions at your end as well. There is the other issue of patients becoming over-friendly because, oh, another doctor says chat kar liya. And then they start sending you messages and they remember things in the middle of the night and they send a message. So when you open your if it's a WhatsApp business account or what have you for clinical assessment, you see a whole lot of pending messages. I tell you, that does not reduce your stress by any count. Then there is the other issue of our female doctors, some of who have had to face harassment at the hands of these perpetrators, these predators who just found their number and said, okay, and they've called and they've done some very embarrassing things. This was featured in a news article and on television a couple of times. But of all these issues, the most concerning issue are the ethical ones. I know that this patient has ADHD. I have to help this patient and I can't send him a physical prescription. When I send him a prescription for methylphenidate, I worry so much that he can take out any number of printouts and he can become the local methylphenidate dealer. A drug so much, the telemedicine guidelines actually don't allow us to prescribe methylphenidate. But what do you tell a mother who has an ADHD or 2 ADHD children in the family? No, please wait, let the pandemic finish, and then, then only we will treat your ADHD children. Also, the issue of benzodiazepine abuse. That is something our telemedicine guidelines have been kind to allow us. But again, you don't know the prescription that you are sending across the PDF, how many times it will be printed, and whether, you want to trust your patient not to abuse that, but things are beyond your hand. The other ethical issue is you may miss out on subtle clinical signs, subtle things which the patient, because they are seated in that chair, they may belie you and you may miss out. You may miss out on vital information. And my worry is, if it were just a minor skin rash we were treating, it was a second thing. It was a different thing. But if you're treating something as serious as a depressed patient who's at risk for suicide, that is a price I'm not willing to pay. For every 50 patients that I treat well online, I do not want to be responsible for that one suicidal attempt. Not that it doesn't happen offline. It can still happen. But online, I worry myself so much. I think most of my colleagues will share this opinion. There is also the pressure of documentation, because I'm seeing this person across a screen. I don't know if I've got enough information. I don't know if I can document enough information. And God forbid, if something goes awry, what I sent out in a few minutes of noting, if that was inadequate, I'm in trouble the same way as I would be in an offline consultation. Only thing is, in an offline setup, I probably have more people to work with, more access to help. It's extremely difficult, this documentation bit, because one is the amount of time available, and this is the pandemic. Everybody's getting in touch happily now online because they don't have to travel and all that convenience that comes with it. But I'm worried of what may happen as an aftermath. Our patients can easily change their diagnosis. A depressed patient can always go into hypomania later on, and that can. So these are things that worry me. It was easier doing these things offline, and this is just a concern that I have. Avinash, I would like to finish with this last quote that, we have human lives at stake here. When you treat a psychiatric patient, you never treat one patient. You are always treating a family. So what you do should not be shortchanged because there is a technological glitch, because there is a technological handicap, because there's something that you will miss out on. I'm so looking forward to being able to see my patients in person. Thank you so much.
Okay. Thank you so much, Josefa. I now hand over to Rukshida. Please go ahead. Yeah.
Thank you, Thank you so much, Dr. Josefa. You've been my senior in KEM, and as the universal tradition continues that, the seniors teach the juniors, and there comes a time where the seniors must learn from the juniors. So I think that day has come today. I have so much to talk about in terms of telepsychiatry and teleconsultation, and telemedicine in itself, isn't it? And so now I'm in a dilemma. Should I go ahead with my monologue, or because there's so many things that I want to rebut in terms of what you've said. But in the words of, Dr. J.K. Trivedi, who writes in WPA, that psychiatry is one of the most dynamic fields of medicine, isn't it? And one of the things, and as clinicians, as we need to practice psychiatry with a lot of caution, right? We need to practice it with sincerity towards our patient based on scientific knowledge and not be guided by individual conceptions, right? And it's also imperative on us to make life not only just patient care easier on the patient as well as the caregivers. We know psychiatry, a big part of it is self-empowerment, isn't it? Even when we're talking about psychotherapy, it's all about self-empowerment. We talk, no evaluation goes without some amount of psychoeducation on our part, and psychoeducation is empowerment. So when we're looking at the essence of psychiatry, which is the topic today, what is psychiatry? We need to kind of start thinking about that, isn't it? So when we're talking about not only looking at a person from a disorder point of view, when we're talking about diagnosing a person with a psychiatric illness or a condition, we are looking at the social factors and the economic factors and the educational backgrounds and all of that, isn't it? So how do we then say that, okay, when there are certain barriers in our life, irrespective of pandemic, let's assume the pandemic hasn't happened or has gone away in the past, and let's just disregard the pandemic. So let's talk about teleconsultation purely on its own merits, and let's talk about the essence of psychiatry and whether it's getting lost in teleconsultations. When we're talking about seeing a person, right, we are also talking about overcoming these barriers, whether those barriers are language based, that I don't understand a language, whether those barriers are a speech impediment or a hearing impediment barrier, where I don't know sign language and my patient cannot read lips, isn't it? I have a patient who reads lips and he cannot read my lips in person because I have a mask on and my patient has a mask on. So it's my job as a doctor, as a service provider, to help overcome those barriers and not to put that onus on my patient, isn't it? If I don't understand the language, I will figure out how to get an interpreter, isn't it? I can't say, oh, you speak Kannada, you know what, you get a Kannada translator. That's not my job as a psychiatrist, especially when you're looking at that we have so many unsurmountable barriers against psychiatry, the list of which is stigma, the least of which is the pathway to a psychiatrist is just ridden with so many hills and potfalls and all of that. And then if we continue to erect more barriers between our patients and our caregivers and us, I don't think any of us will be forgiven for that. So when we are talking about from like an evidence perspective, right, especially because of the pandemic, now we have more evidence for and against teleconsultations of all kinds, including psychiatry. I can share a lot of articles with you. Some of them have been provided by Dr. Malay Dave. As usual, he's my go-to library guy. So I can provide all of these articles to you that will suggest to you that yes, there are certain barriers, but when you were talking about in-person consultation as well, Dr. Josefa, you talked about barriers as well. So nobody's saying a particular way of doing psychiatry is perfect in itself. But does it lose the essence? Not at all. For the simple reason, first, I have more patients now coming in from different parts of the country than I had before. For the simple reason, now the government in its wisdom has made it easier and possible for us to work like that. That means the barrier that they had, that they didn't want to go to somebody close by or in their city, or they wanted to consult especially me or Dr. Uzefa, now no longer have to worry about, oh, how am I going to get from point A to point B? So the accessibility has improved. That is essence of psychiatry. The ease has improved. They can contact me from any part of the world or any part of their time. That is essence of psychiatry. When a person comes to me, especially let's say I'm sitting in my general OPD where a person cannot afford private fee, and so there's one patient, there's at least one caregiver. So the patient has to take off from work, the caregiver has to take off from work, so that's money lost. Then they have to spend that money in traveling, that's money lost. Then they have the waiting period because it's first come first basis, that's time and effort loss. Then they see me and then they take medications and then they go away, isn't it? So when we are reducing that, right, we're reducing the time and effort for our patients. That's essence of psychiatry. When we are talking about the overall cost and the overall burden of seeking help, when that is reducing with help of teleconsultation, that is essence of psychiatry, which is in fact getting pronounced instead of getting diluted because of teleconsultations. We know, and if we'll come to the barriers, but when we're talking about patient comfort, right? And when we're talking about patient comfort, we've already described that it might be so much more economically viable for them, time convenient for them. I have more corporate patients who are willing to see me in the middle of the day, in their lunch break or coffee break or something like that, and not really expecting me to work late hours so that they can finish their corporate work, then come see me. Legit, I've had people coming and saying, okay, I'm going to come back from work at 8. I'll quickly grab some dinner, then I'm going to come see you at 9, because doctors are not human beings and we don't have dinner. So that kind of goes away, isn't it? And they are so much more happier. Their work-life balance is better. And the grudge that they used to have with their employees, that my colleagues in the Western world, they get time out to go see the doctor. And here I'm like, forever getting just working, and I can't even get to see my doctor. So that overall frustration has gone down, isn't it? So, and when we talk about the barriers, the way Dr. Huzefa was describing is all about just frankly upskilling our own skills, isn't it? So as psychiatrists, as clinicians, are we afraid to do that? Are we afraid to now adapt to technology or better ways of reaching our patient and treating our patient? As far as so now I can, like I said, go on and on with my monologue, and I'm not really doing a sell job for telepsychiatry. I'm sticking to my point. Does it miss out on the essence? I am saying it doesn't, because like I said, first, the accessibility, the availability, the ease is absolutely okay. When we are talking about barriers of technology, I can talk about barriers of season. I live in Mumbai. Because of the mangroves going away, every year we have flooding. That means my patients can't get from point A to point B. If I have a patient coming from South Mumbai, they want an afternoon session so that they can go back home in time. So there are so many kind of different reaching barriers there. When we're talking about technology barriers in terms of network issues and all of that, yes, they can overcome. We can overcome all of those things. If I'm sitting in my clinic or in my hospital and the electricity goes out and we're in the dark, what do we do then, right? So we don't say that, okay, now we pack up and like, you know what, I'm not going to see you anymore. We don't do that. So again, telepsychiatry does not take away from the essence of psychiatry. When he brought about that, okay, face-to-face hearing, communication, yes, those are all great, but adaptation is the name of the game. That's how we evolve, and that's how we continue to be, we continue to survive our elements, isn't it? And telepsychiatry is about that. It's about adapting and evolution, improving ourselves and improving our communication skill, especially in view of, like I said, even irrespective of the pandemic, where people were so much more used to reaching out to their loved ones, talking to people on WhatsApp videos was very, very common at that time. They would stay in touch with families and friends. So they were, a lot of them were already okay with this kind of communication. So, when we're talking about missing out on body language and we're talking about missing out on other nuances, frankly speaking, if I am sitting in a clinic, I'm behind a desk, they're sitting in a chair, am I really seeing them more than what I would see Dr. Zephyr right now on Zoom? Not always. You know what, it's very easy for me to adapt if I think that, oh, you know what, why don't you walk around, let me see how you're doing. So many times they are so much more comfortable when I'm talking about observational skills. When they come to my clinic, they're all cleaned up, clear, wearing, like, they're outdoorsy, outdoor visiting clothes. But when I'm seeing somebody in their natural environment, they might not be so well dressed, and that might actually give me an indication of whether my patient with chronic schizophrenia is being treated the same way as when they are cleaned up for their visit when they come to the psychiatrist, isn't it? I might get hints of domestic violence that otherwise I wouldn't have figured out. When we're talking about privacy, how often is it that, we will, in person as well, that the doctors are the ones who have to say that, no, I would like to speak to the patient alone, kindly wait outside. And why can't we do that when we're online? How different is it? How difficult is it? Because for a fact that whether we're talking about marital disharmony or somebody with paranoid schizophrenia, it's very difficult for the person to say that I want to talk to the doctor alone, because they're so worried about offense or repercussions when they go back home. So here, anyway, that's something that we pick up on, and we suggest that we want to talk by themselves. As far as privacy is concerned, they are worried about, even when they come to the clinic, that my voice is going to go outside, because now most of our facilities are not soundproof. But I have people who are doing sessions with me, consultations with me from their cars. They've gone out in the building lawn, and they're talking to me from there. So we have they have overcome those barriers, and we are saying we can't, and we are saying that we cannot upgrade our skills even though our patients might benefit from it. I don't think that's essence of psychiatrist. And of course, then that's going to impact the essence of psychiatry, isn't it? I think I have 2 more minutes, but I will take up some more points in the rebuttal. But definitely, when we are talking about, okay, can I see the wrist or can I see the arms? You know what? If a person has self-harmed, they will come with full sleeves. Doesn't mean that it's okay for me to miss out on those, isn't it? I'm still going to verbally ask them, oh, is there a history of self-harm? I don't go ahead and show me your wrist, show me your forearm. I know you're lying to me. We're not combative. We're not aggressive. That's not motivational interviewing, isn't it? That's not what we do, because that's the opposite of essence of psychiatry. We don't subtly check out our patients. That would again be a violation of them. We are going to do, eye to eye contact. That is essence of psychiatry, which we are not really going to miss out on when we are doing teleconsultation. When we're talking about social anxiety people, yes, they could be they are better, they're talking better because they're communicating better, the therapies and the sessions are going easier. That will translate an easy kind of step ladder approach to when they are going to go ahead and meet people in real world. So in fact, it's not in fact a hindrance in social anxiety. So many people have flourished because of the pandemic, because they've learned these skills during the pandemic to overcome it. For a paranoid patient, a person with paranoia, you know what? You put them in charge. You tell them, you call me up from wherever you want, whether it's Zoom, whether it's Google Meet, whether it's another kind of like a formal portal that we, it's better if we use those formal portals, which none of us really have progressed to as of right now. And they're absolutely okay, because they are more in control of that environment than they are ever in my clinic, where I may have hidden cameras and she doesn't know about it. So when we're talking about, barriers of our patients or barriers of our physicians, the barriers of our patients, it's our job to help them overcome them. The barriers of our physician, it is imperative.
30 seconds, Rukshida. Yeah.
Yes, this was my last point. The barriers of the physicians and the clinicians, it is the onus on us that we upscale us and not say that, oh, because I don't know how to use telepsychiatry, that means that the essence of psychiatry is lost. Not at all. So I think, with this, my time's up and I leave the floor to the moderator.
Well, Josefa, now is your chance for your rebuttal. So you get around 4 to 5 minutes for your rebuttal. Yeah. You unmute. You'll have to unmute yourself.
Am I audible now?
Yes.
You know, unfortunately, challenge is what Rukshida is calling barriers. And I am not close to seeing patients online. No way. I have seen a lot of patients online. I'm glad that we had this facility. My only concern is the quality of interaction. It's more a matter of convenience, both for you and for the treating doctor and for the patient. But convenience comes at the cost of quality of response, quality of improvement that the patient experiences. Every patient that I have spoken to, every single one has said, "Sir, ye to theek hai, but when will we see you in person?" So that gap is something. As a psychiatrist, I feel that there is so much that the gap is still there. The issue of privacy and confidentiality. I think if people are calling me at lunch break consultations, or if people are speaking to me from the car, really how much of their attention is with me and how much am I able to respond to that? It is just a concern I have. A person calling you at lunch break, really, I mean, amazing. Because lunch breaks are not, expensive and available. That's fact. Never before have I had so many patients complaining of dissatisfaction with a consultation, because they feel that ये ठीक है कर लिया because अभी pandemic है, but we want to come and see you in person. Or domestic violence. I'm a little surprised that more people will talk about domestic violence on the screen rather than in the privacy, in the seclusion of a consulting room. But then again, everybody can have a difference of opinion, which is just perfectly all right. Also, deliberate self-harm patients. I feel this is both deliberate self-harm patients and conversion disorder patients. What the rapport you can build with a conversion disorder patient, because you need them to be open to your suggestions, is completely lost across a screen. I'm sure Rukshida has, and a lot of people have come out with challenging ways of, being able to win over. But that is something that I'm still taking baby steps in dealing with my conversion disorder. That's a very big challenge. And what you can do in person cannot be compensated nearly by across a screen. It leaves me with a sense of dissatisfaction. It leaves my patient with a sense of dissatisfaction. I know there is so much more that could be done. That human touch, sometimes that little pat on the back, or just handing over a tissue to a crying patient. These are things that you simply cannot do. You can say verbally what you want, but being in the same four walls and being there for the patient, allowing the patient to express themselves openly without any pressure, that's something that a face-to-face human interaction can do. That can never be taken up by screens. Just my 2 pence. Over to you, Avinash.
Yeah. Yes, Rukshida, please go ahead. Yeah.
Thank you. So just like at the outset, when I said that psychiatry isn't about anecdotal evidence or personal viewpoints, isn't it? So it cannot be about Dr. Zaifa's experience or my experience. What I'm saying is backed up by data that I'm happy to share with anybody who wants to ask me. When we're talking about, he brought about convenience. Yes, convenience is one of the biggest things, isn't it? When we're sitting in metro cities, and we're, our city has, thankfully, Mumbai has the largest amount of concentration of psychiatrists. But when we're talking about smaller towns or villages or talukas, where they see one psychiatrist maybe once a week, and that psychiatrist ends up seeing 300 patients in that day. So that is that gap is definitely something that we have overcome with telepsychiatry. And again, that's the essence of psychiatry. There are different models of telepsychiatry where a general physician is seeing a patient with his own eyes, and maybe I am sitting in a remote area and doing teleconsultation. If we didn't do that, we couldn't really reach a lot of people in war zones or disaster zones, and they would not be able to give them that vital and critical care maybe at that time. And who's to, and of course, like a suicidal idea attempt or a suicidal idea is a medical emergency, isn't it? When we're talking about privacy, there are now more number of patients who are so much open to coming for therapy, for coming for consultations, taking medications, because nobody's asking them on their way to the hospital, oh, who have you come to see in the hospital? They don't see that, oh, you're going to Dr. Rukshida's clinic. They don't, so they have more privacy, they have more confidentiality. And I know for a fact that a lot of my celebrity clients, they're so much happier seeing me online, because then that gives them more, they can see me from anywhere, and they don't have to worry about who's seeing them. They don't have like a baseball cover, hat covering their face. So when we're talking about privacy, of course we have so much of privacy, so much more privacy and more confidentiality. And when we're talking about documenting, how is documenting that difficult? How is it, how, if we feel that, okay, risk assessment of suicidality is difficult, most of the times anyway, when we're getting a call, talking to people for suicidal ideas, we do our first risk assessment is over a telephone call, not even on a Zoom call. So I think, again, these are clinician barriers which can be easily overcome by our own education and upskilling our skills. And it's not something that takes away from the essence of psychiatry. Human touch is a very different thing. And you know what? I've had sessions where people are breaking down, and if they say, I'm so sorry, I'm crying, because that's what everybody unfortunately even now says, I will say, you know what, don't worry about it, I'll wait. Why don't you, if you want, go get a grab a tissue, go get a glass of water. That gives them that kind of sense of comfort, because they're in their zone, they're in their comfort area. So again, that's improving essence of psychiatry, not taking away from them. Yes, senior citizens, yes, literature also says more younger people are happier and more more for taking consultations, because it's via teleconsultation, than senior citizens. But that is again something that we can overcome. A lot of the times when people, a lot of our hospitals unfortunately don't have wheelchair access, so the senior citizens anyway find some barriers to reach us there, isn't it? When we're talking about, female doctors getting harassed, trust me, when I'm doing teleconsultation, most of my patients don't have my direct contact. But you know how many patients can get my direct contact? If they want to harass a female, whether that's a female physician or just anybody, it's so easy. All of us are so Googleable, isn't it? So again, as far as if you're going to tell me that the harassment has increased because of teleconsultation, that mansplaining bit I'm definitely not going to accept and agree to. When we're talking about ethical abuse, you understand that again, there is a system in place already to avoid certain situations where when a person is going to a chemist to get those medications, even if it's a printout of my prescription, they get stamped, so they cannot really use it. Yes, they can reprint it, but I have had patients who've gone ahead and printed an entire letterhead and got my rubber stamp from somewhere as well, and has been using and abusing, had abused medications for a good 6 months before confessing the crime to me 10 years ago. So that's something, if somebody wants to abuse, the potential of abuse is always going to be around. And that's why you develop a rapport. Now, coming back to rapport, because you brought that topic as well, I am telling people, first session, please do online, because I'm going to be in a mask, you're going to be in a mask. It will be a little difficult for us to see each other and build that rapport. Maybe after that, if you want to come, you come in person. And that makes sense to them. So as far as building rapport is concerned, again, because of the pandemic, at least as of right now, it is improving the essence of psychiatry and not taking away from it. I think my 5 minutes are up. And with that, I thank you very much. And over to you, Avinash.
Well, I think we've had an excellent debate today. We definitely, of course, all of us practice online consultations, but we all also definitely miss a clinic based consultation. I wouldn't say that the online consultation is bad. I won't say that what is better. Probably the need of the hour is what we are adhering to. And I think the debate has been fairly even. I wouldn't say there's a winner here, because we all practice both and we know what works and what doesn't work. In fact, we're adapting to online and making it work, while we do know that, yes, the purest form is, of course, an offline consultation, and we're working towards in that direction. Though, yes, online is here to stay. It's the future, and it's something that we're going to do more and more. So we can't shy away from that. We can't run away from that, and we have to do it. So I guess it's going to be a fine blend of both in our practice in the long run. With that, I want to thank Josefa and Rukshita for taking out time on a busy Wednesday evening, peak practice our time, 7 to 8 p.m., and doing this. So I thank you both for being here. I have one announcement to make, that we have a program coming up on Sunday. At 7 p.m., 7 to 8:30, we have a panel discussion on LGBTQ plus mental health issues, considering June is the Pride month. Our panelists are Dr. Jyoti Shetty from Pune, Dr. Cheryl, our own treasurer of BPS, and consultant at Hiranandani. We have Dr. Prasad Dandekar, who is a radiation oncologist at the Sir H.N. Reliance Hospital. We have Palo Patankar, who is the voice of the LGBTQ plus community, and Nishta Nishant, who's a trans woman and a scientific researcher. So we have a mixed panel. So please do join us on Sunday if you can. It will all reach you, the details, by mail. Priyanka will send out a mail soon. And thank you for attending. Even today we've had 50 plus attendees, so on a weekday, which we're very happy about, and the debate will be there on YouTube for all of us to see. So I think with that, I would thank all my the secretary, Astek, the EC members who all made this event happen. Without them, I mean, I am no one. It wouldn't be possible without all their help. Fabian, Cheryl, Ami, for all being there always and supporting. And thank you, and hope to see you soon in our next event. Okay, good evening. And
So Josefa sir wants to say something.
yes. No.
Can we also get psychologists to attend this Sunday evening?
Yes,
Okay.
of course.
In terms of doing some.
Yeah. No problem. No problem.
Sir, I'll share the link with all the BPS members.
Yes, I will send you the link, Josefa. You forward it to them.
Yes.
No problem. Yeah.
Bye. Thank you.
Okay. Yes.
Bye everyone. Good night.
Bye.
Bye. Bye.
Yeah.
Great show. Thanks for the information.
Yeah. Bye.